Welcome to this quick review of the abdomen together with Anatomy TV. Here we're using the 3D interface. If you have your 3D glasses, please put them on now. If you don't have them, it'll still work, it just won't be quite as good. So here we have actually removed the first two layers of tissue. We have removed the campus fascia and the scarpa fascia. We're looking straight down at the external oblique aponeuroses. Yeah? If we look at the side here, here is the first layer of muscle. Note the fiber orientation, same as the external intercostal muscles, which would be superior to this. This is the external oblique. External oblique goes over into the external oblique aponeuroses to contribute to the rectus sheath. Here is the anterior rectus sheath. Okay, one of the nerves that we can see poking through here is going to be the iliohypogastric nerve. Note that the iliohypogastric nerve comes from L1, and also from L1 comes the ilioinguinal nerve, with the difference that the ilioinguinal nerve, as you can see here, comes right out of the superficial inguinal ring. Okay, so this here will actually traverse the superficial inguinal ring and travel through the inguinal canal. Also traversing the superficial inguinal ring is going to be, in females, the so-called round ligament of the uterus, and in males, the spermatic cord. So if we now switch over to a virtual male cadaver, we can see that exiting out of the superficial inguinal ring is going to be the spermatic cord. Okay, this is easy to localize because the spermatic cord goes all the way down into the testes, and one of the main components within the spermatic cord, in addition to the testicular artery and vein, is the vas deferens, which you can see traveling within it right here. If I click on the context view, we can see everything else kind of like a radiograph, kind of shadowed like this, so we can see the spermatic cord exiting out of the abdominal cavity. Now highlighted is the cremasteric fascia, which we know is an extension of the internal oblique fascia. And now, as I have deselected all of those items, now we can actually see the testicular artery and the ductus deferens, aka the vas deferens. So, and if I now flip this over and we can have a look at the inside, we can see here the posterior rectus sheath has been removed. Here we still have the posterior rectus sheath intact. And you can see nicely that down here the rectus abdominis is exposed because actually all of the aponeuritic layers of muscle are going anterior to the rectus sheath. Up here the internal oblique splits, and so we have the rectus abdominis enclosed in part of the internal oblique aponeuroses first. Anteriorly, external oblique, internal oblique. Posteriorly, we have the transversus abdominis blended together with the fascia of the internal oblique. Now let's quickly go through the layers of the anterior abdominal wall just with the 3D Atlas of Human Anatomy from Primal Interactive. On the outside here is the Camper's fascia, the superficial fatty layer. We can see the anterior rectus sheath. In the midline will be the linea alba. Then we have the external oblique and external oblique aponeuroses if we have a look at the side and moving from laterally to medially. If we remove the external oblique, we can see the internal oblique and the internal oblique aponeuroses. Here you can also nicely observe, if we compare these two layers, external oblique, look at this fiber direction here, internal oblique, perpendicular to that. That should very much remind us of what the fiber direction looks like in the external and internal intercostal muscles. Going one layer deeper, we can now see the transversus abdominis muscle. The fibers are running transversely. The fibers will actually end in an aponeurosis which fuses with the posterior layer of the internal oblique aponeuroses. The upper 3/4 of this sheath are going to be attaching to the linea alba and the xiphoid process. Right here is the rectus abdominis muscle, actually the two halves of the rectus abdominis muscle, this paired vertical midline muscle. This muscle receives its innervation from ventral rami from the lower 6 or 7 thoracic nerves. If we now remove the rectus abdominis, we can actually see some more of the neurovasculature that is in front of us. Highlighted now are the inferior epigastric arteries on the right and on the left side. This is actually an important landmark and an important region for us to appreciate properly because the inferior epigastric arteries go superiorly from their origin of the external iliac arteries, and then they ascend towards the umbilicus and pierce the transversalis fascia down here right there where they start passing in front of the arcuate line. And as you can imagine, they will be supplying the rectus abdominis and the abdominal wall. Down here, below the arcuate line, the rectus sheath is going to be comprised of the layers of all three of the abdominal muscle aponeuroses. So that would be the external oblique, internal oblique, and the transversus abdominis. If we move above the arcuate line here, where we can now see the inferior epigastric arteries and veins, here the internal oblique splits in two, and so the part of the internal oblique and the transversus abdominis contribute to the posterior rectus sheath, whereas the anterior rectus sheath above the arcuate line is then only made up of the external oblique aponeurosis and half of the internal oblique aponeuroses. Moving one more layer down, we have removed all of the rectus sheath, and now we are looking straight down at the parietal peritoneum. One important thing that you can see here is that you have the umbilicus, and attaching to the umbilicus is the median umbilical ligament, which is the ligament that contains the urachus, which is an embryological remnant that used to connect the bladder and the umbilicus. Slightly lateral to this, we have the medial umbilical ligaments. These will contain the obliterated umbilical arteries, and the lateral umbilical ligaments, which are not really depicted very well here, but the lateral umbilical ligaments will be containing the inferior epigastric arteries. So you have lateral, medial, and a median umbilical ligament. Let me quickly add some more layers of tissue back in here and point out these two nerves that we should have also seen in lab. Here is the iliohypogastric nerve, which is from the L1 anterior or ventral ramus, and down here is the ilioinguinal nerve. The difference between these, although they are both from L1, is the ilioinguinal nerve actually, after arising from the L1 ramus, emerges out of the superficial inguinal ring. So it passes through the inguinal canal. So to wrap up the external features of the abdomen, let's have a look at this cadaveric image here. First, we can see labeled an anterior cutaneous nerve, which represents the 10th intercostal nerve. Next, we can see highlighted the anterior layer of the internal oblique aponeurosis, followed by the anterior wall of the rectus sheath. Then we have the 8th rib, or the location of the 8th rib, highlighted here. Here's the external oblique aponeuroses. It's the most anterior part, deep to all of the fatty tissue, fatty subcutaneous tissue. The external oblique muscle is just lateral to its aponeurosis, logically. Here's the ilioinguinal nerve. As we know, this here will be passing through the superficial inguinal ring. Here are the inferior epigastric vessels. Here is the internal oblique aponeurosis reflected a little bit here. The internal oblique muscle itself, just as with the external one, is prior to the aponeurosis. There is the linea alba in the midline, the mons pubis, the posterior wall of the rectus sheath, the rectus abdominis muscle, the reflected part of the rectus abdominis muscle, the round ligament of the uterus, because in this case we are dealing with a female donor. Here are some superficial inguinal lymph nodes. These are tendinous intersections. These are the ones that are responsible for making the 6-pack or 8-pack appearance of the rectus abdominis muscle. Here is the transversus abdominis muscle, the third layer of these three major flat paired muscles, and right here is the umbilicus. Okay, so now let's move into the inside of the abdominal cavity. First off, what we have to be aware of is that actually the entire abdominal cavity will be lined with peritoneum. And just as we've encountered previously, in the thorax there is the endothoracic fascia and there is the pleura of the lungs, and similar to the visceral and the parietal pleura that we have in the thorax, we're going to have visceral and parietal parts of peritoneum. The peritoneum will be lining all of the inside of the abdominal cavity and also extend into the pelvis. The visceral peritoneum will cover the surface of the abdominal and pelvic organs. So the space that is in between these two types of peritoneum, we can actually call the peritoneal cavity. If we now have a look at the inside of the abdominal cavity, the first major big organ we're going to see is going to be the liver. The liver has a very large right and left lobe. And right in between these, you will find this double layer of peritoneum, which is called the falciform ligament, within the inferior free margin of the falciform ligament, you will find the round ligament of the liver, also called the ligamentum teres hepatis. This is actually an embryological leftover. If we have a look below the liver, we can see the gallbladder nested right in here. Now I've added in the stomach, and the stomach lies in the upper left quadrant. We can actually subdivide the stomach into several regions. Okay, there's the body of the stomach right here. Up here is the fundus region of the stomach. After the body of the stomach, you will have this region here, which is called the pyloric canal. Before the pyloric canal is this here, which is called the pyloric antrum, which is kind of the region that leads into the pyloric canal. And after the pyloric canal is the actual pylorus, which then contains also the pyloric sphincter, which leads directly into the duodenum, which is now visible, highlighted here in green. I've now ghosted the pylorus and the pyloric canal that we can actually have a look right in here. This is where the pyloric sphincter would be. If we were to follow this, we will end up going right into the duodenum, which is located right here. The duodenum itself is actually C-shaped, as we can now appreciate. That's going to be important to understand because it'll actually end up cradling the pancreas, specifically the head of the pancreas. As you can see here, the duodenum starts at L1 with the first part. The second part goes down to L2 and then L3, where the third part, or horizontal part, takes over. And then the fourth part is a little part of it which ascends again back up to L2. So L1, L2, L3, L2. If we locate the spleen right up here, we can actually also appreciate that the tail of the pancreas extends all the way to the corner on the left side where the spleen is lying. This is why some anatomists may say that the pancreas is the most promiscuous organ in the body, because although its head is cradled by the duodenum gently, its body extends over to the left until its tail ends up tickling the spleen. Okay, so now we're going to continue working our way into the abdominal cavity. One of the first and pretty large structures we're going to see is the greater omentum. The greater omentum actually can move in the peritoneal cavity. It can, for instance, help to seal off an inflamed area, for instance, if the appendix becomes inflamed, so it can help to limit the spread of infection. Yeah, the greater omentum also has been termed the so-called policeman of the abdomen. Okay. In addition to that, it'll also help cushion against injury and provide insulation to prevent loss of body heat. So here's our stomach. Hanging off of the stomach here is the transverse mesocolon. The transverse mesocolon helps attach the transverse colon, which begins up here at the right colic flexure and then goes all the way over to the left colic flexure. If we go down here to the right lower quadrant, we can see that here is the cecum, and attached to the cecum is the vermiform appendix, lying right here. Usually the position of the appendix will be retrocecal. That means it'll actually be tucked behind the cecum. Also note that the location of the appendix is usually where McBurney's point is, so it's about a third of the way between the ASIS and the umbilicus. Now let's hide some of the transverse mesocolon. And now we can actually have a look right into here. Here would be the ascending colon that is actually going up into the right colic flexure. Now we can have a look at it from the side. Remember that the ascending and descending colon are actually secondarily retroperitoneal. Here's the ascending colon, here's the cecum. The cecum will be attached here to the ileum. And if we follow the ileum, although there's no very distinct transition between the ileum and the jejunum, the ileum and jejunum will then connect to each other, and we know that the jejunum has to begin at the duodenum. So now let's have a look at some of the vascular supply of our intestines. Okay, so what's next? We are going to look at celiac trunk. And here it is. Celiac trunk is actually going to be the first major blood vessel that we're going to encounter in the abdomen. Okay, so celiac trunk has several branches. Yeah, the first one that's coming off here is going to be the left gastric artery. Then you have the splenic artery going over to the spleen, as you can see right here. Then you have the rest of the celiac trunk is going to be the common hepatic artery, which then will bifurcate into the descending gastroduodenal artery, which also gives rise to the right gastroepiploic artery, which supplies part of the greater curvature of the stomach, and then anastomoses with the left gastroepiploic, or also called gastroomental artery, which in itself is actually a branch off of the splenic artery. If we continue here now, from the common hepatic artery, we have a look over here. This is the hepatic artery proper. It's a hepatic artery proper because it will actually be coursing in the hepatoduodenal ligament together with the portal vein and the common bile duct. Right here would be the portal vein, and if I add in the common bile duct, then we would have the portal triad complete. So you can see that this picture is getting very busy, so I'm going to hide that vein again. And so back to the hepatic artery proper. The hepatic artery proper will then give rise to the right and left hepatic arteries. And similar to the right and left gastroomental arteries, you have the right gastric artery here, which supplies the lesser curvature of the stomach until it then anastomoses with the left gastric artery, which we can see right here. So let's have a look at one more thing here, which is an important clinical correlate for us to know. Look at the pancreas, which is highlighted here in green. Now I'm going to hide or ghost through the pancreas so we can see the underlying structure. Right here is the superior mesenteric artery, and if we have a look at it from laterally from the side here, you can see that the SMA will be passing anterior to the left renal vein, which is running from right to left here, crossing over the abdominal aorta, and the SMA also crosses anterior to the third part of the duodenum. So a syndrome that can occur is called the nutcracker syndrome, because we have the left renal vein and the duodenum running inferior to the SMA. What can actually happen is that you compress either of these two structures. If the renal vein is involved, it will be called renal vein entrapment syndrome, or mesoaortic compression of the left renal vein. In superior mesenteric artery syndrome, or SMA syndrome, what is compressed is actually the third part of the duodenum, and this may prevent food from passing through the duodenum into the adjacent jejunum, so it can cause nausea and vomiting. Renal vein entrapment syndrome, on the other hand, can lead to hematuria and abdominal pain. In addition to that, since the left gonad, specifically in this case the left testicle, drains into the left renal vein down here, okay, you can imagine that it can result in left testicular pain, and it could actually exacerbate a condition called varicocele of the pampiniform venous plexus. Okay, so now to finish up, let's have a look at some of the associated cadaveric anatomy. First off, here is your epiploic foramen. Remember from lab that the epiploic foramen is the area when you put your index finger through here in this direction, so from right to left, you actually end up with your tip of your finger in the lesser sac. Anterior to your finger then is going to be the hepatoduodenal ligament with its contents, which is the portal triad. So it's the portal vein, the proper hepatic artery, and the common bile duct. Okay, so right here is then the hepatoduodenal ligament. This is the gallbladder fundus and the gallbladder body. In the top of the picture here is the right lobe of the liver. Here's the quadrate lobe of the liver. Here's the obliterated left umbilical vein, also called the round ligament of the liver, or ligamentum teres hepatis. There's the left lobe of the liver. And in this corner is the body of the stomach. Here's the pyloric antrum, continuing to the pyloric canal, which will then go into the pylorus. And we know that after the contents is passed through the pyloric sphincter, it ends up in the duodenum. Yeah? First, second, third part is not in view here. Okay, now let's have a look at some of the mesentery and the descending colon and associated structures looking from the front. First off, here where the arrow is located, here is the duodenal jejunal flexure. Okay, the descending colon is highlighted right here. Remember, it's secondarily retroperitoneal. The sigmoid colon is adjoining the descending colon. Up here is the transverse colon, and the left colic flexure is going to be located right here where the little arrow is now. You're going to have peritoneum that will be overlying the external iliac vessels. You also have peritoneum that is covering the mesentery of the small intestines. Here's the peritoneum of the sigmoid mesocolon, and there is the root of the mesentery by which it attaches to the posterior abdominal wall. Then here is the horizontal or third part of the duodenum, and the jejunum and ileum are now highlighted here. Remember, they don't really have very distinct demarcations where one or the other starts. And the greater curvature of the stomach is outlined right here. So now let's continue here with the superior mesenteric arteries. Again, an anterior view here. So here's the duodenal-jejunal flexure. There is the ileocolic artery in green. Jejunal and ileal arteries are here. The descending colon again on the left side. The transverse colon again going horizontally on top. Here's a little edge of the left kidney. You can see a little bit of the middle colic artery traveling right down here. And it's a branch off of the superior mesenteric artery. Here's the body of the pancreas, as you can see, anterior to the superior mesenteric artery. There is the head and the neck of the pancreas, and the little uncinate process as well. Here's the mesentery of the small intestine. Here's the second part of the duodenum, which is the descending part. And here's the horizontal part or third part of the duodenum. Here's the jejunum. Here's the posterior surface of the stomach. And there again is the SMA. And right next to it is the SMV. So now let's have a look at some of the branches of the celiac trunk in a cadaveric dissection. You have the common hepatic artery coming off here. Then you have your hepatic artery proper and the right and left hepatic arteries. Posteriorly to that is the portal vein. A little branch that's coming off here is the cystic artery. Passing inferiorly is the gastroduodenal artery. We can see the gallbladder on the left of the screen. Here's the body, and there's the fundus. The inferior vena cava is kind of behind all of these structures. It's kind of shadowed and outlined now. You can see part of the ascending colon in the bottom right of the screen. The transverse colon is going horizontally across the screen now. Here's our left gastric artery coming off of the celiac trunk directly. Here's the left renal vein. We know that the left renal vein will pass inferior to the superior mesenteric artery right here. The right gastric artery actually is a really small little branch that's illustrated here now. Here's the right gastroepiploic artery. Here's the beginning of the duodenum. There's the splenic artery. And here are the parts of the stomach, starting off with the body, the cardiac region, the fundus, the pyloric antrum, the pyloric canal, and finally the pylorus, which then leads into the duodenum.